Okay, let's tackle something that, often feels like wading through just loads of medical jargon when you're trying to revise,
Uh-huh.
especially these complex, rare conditions.
Right.
So today, we're doing a deep dive specifically into Ataxia Telangiectasia, or AT.
Right. AT.
We're using a set of MSRA revision notes as our guide here.
Good source.
And our mission really is to pull out the absolute high-yield information, the stuff that actually sticks and helps you understand it and hopefully ace that part of the exam.
Exactly. AT is definitely one of those multi-system genetic disorders you need to, well, get a solid handle on. So we're going to work through what these notes cover, the definition, the causes,
Right.
who's at risk, how the whole faulty gene thing causes the problems,
How it works, yeah.
what it looks like clinically, diagnosis, management, prognosis,
Yeah.
and, of course, the main complications you need to watch out for.
And we'll try and make it really clear, memorable, and, genuinely useful for your revision. We'll throw in some memory hooks, maybe think about how these points might pop up in an exam.
Sounds like a plan.
So let's jump straight in. At its heart, what exactly is Ataxia Telangiectasia?
Okay, so fundamentally, it's a rare genetic disorder. It's progressive, meaning it gets worse over time. And when you think AT, you should really think three key areas it hits hard.
Okay.
The nervous system, that's where the ataxia, the coordination problems come in. Then the immune system. And third, it significantly bumps up the risk of developing cancer.
And the genetics behind it. You mentioned genetics.
Yeah, follows an autosomal recessive pattern,
Right.
which, means you need to inherit a faulty copy of the gene from both parents to get the condition.
And is there a specific gene?
There is. It's called the ATM gene.
Mm-hmm.
Mutations in this gene lead to a deficiency or sometimes complete absence of the ATM protein.
Okay, so summing that up for revision, AR genetic disorder, faulty ATM gene, and it hits the nervous system, causing ataxia, the immune system, and increases cancer risk. That seems like the core definition.
That's it. That's the absolute core concept you need.
Perfect. Now, how does that dodgy ATM gene actually cause all those different problems? What's the etiology we're looking at here?
Well, the primary cause is those mutations in the ATM gene.
Yeah.
And this gene, it has a really critical job. It's basically a master controller for detecting and repairing damaged DNA.
Ah, okay. DNA repair.
Exactly. It helps maintain the stability of our whole genome.
So when that protein isn't working properly.
Precisely. If you've got a deficiency in the ATM protein, that whole DNA damage response system is impaired.
Yeah.
It can't fix breaks properly.
And that causes the wide range of symptoms.
Well, this genomic instability particularly affects cells that are dividing rapidly.
Sure.
Think about the developing nervous system, the immune system cells. They're really vulnerable.
I see.
Now, the notes do mention, and it's important, that the precise molecular links between the gene mutations and, the full range of symptoms, they're still pretty complex and not entirely mapped out.
Right. Still some unknowns there. So knowing it's genetic, who's typically at risk then?
The main risk factor flows directly from that inheritance pattern, the autosomal recessive bit.
Okay.
So you're at risk if you happen to inherit two mutated ATM genes, one from your mom, one from your dad.
Which means the parents being carriers is the key thing.
Exactly. If both parents are heterozygous carriers, so they each have one mutated copy but don't have AT themselves, then there's a 1 in 4 chance with each pregnancy that the child will inherit both copies and have AT.
And does family background matter? The notes mention consanguinity.
Yes, that's relevant.
Yeah.
In populations where marriage between close relatives, consanguineous marriage, is more common, the chances of both partners carrying the same rare mutation, like the ATM mutation, go up. So that increases the risk in those specific groups.
But overall, it's still considered a rare condition.
Oh, definitely. It is rare. So for the general population, the overall risk is low.
Let's dig a bit deeper then into the pathophysiology. We know that ATM protein's faulty DNA repair is off. How does that specifically cause, say, the progressive neurological issues, the ataxia?
Yeah, it's kind of fascinating, isn't it, how this one protein causes so much trouble. Because ATM is so vital for that DNA repair and keeping the genome stable, its absence means cells just accumulate DNA damage they can't fix properly.
Right.
Particularly double-strand breaks. Now, in the classical form of AT, where you've basically lost function from both ATM genes, this impaired DNA repair is thought to hit the cerebellum particularly hard during development and, well, throughout life. The cerebellum's crucial for coordination.
Ah, so the cerebellar cells are vulnerable, they degenerate, and that causes the ataxia.
That seems to be the main thinking, yes.
Yeah.
Progressive cerebellar degeneration leads to that progressive ataxia.
And what about the immune system side of things? Same mechanism.
Pretty much. Again, think about rapidly dividing cells. Lymphocytes, the cells of your immune system, they divide a lot. So they're also really susceptible to this buildup of DNA damage and the resulting instability. This leads to immune dysfunction, making people prone to infections, and also linking back to malignancies, especially lymphoid cancers. The notes, again mentioned, there are complex molecular details still being worked out.
Sure.
But that core link, ATM, DNA stability, vulnerability of nervous and immune cells, that's the key pathophysiological concept. Oh, and it's worth remembering, the notes mention milder forms, too. Different mutations might leave some residual ATM protein activity, leading to a less severe picture.
That makes sense. Okay, so shifting to the clinic. If you see a child, maybe with some of these symptoms, what else might be on your mind? What other conditions do you need to rule out?
That's a really important practical question. You definitely need a differential diagnosis list. You're looking for other things that cause ataxia, maybe immune issues, perhaps increased cancer risk.
So what are the key ones mentioned in these notes to differentiate from AT?
The main ones listed are Friedreich's ataxia, another inherited ataxia,
Right.
other types of spinocerebellar ataxias, and conditions primarily affecting the immune system, like X-linked agammaglobulinemia, although that presents differently.
And how do you tell them apart?
It really comes down to a thorough clinical evaluation, looking at the specific pattern of symptoms and the timeline, but then you need investigations.
Right.
Genetic testing is the gold standard for AT, looking for those ATM mutations. But you'd also use imaging, like brain MRI and specific immune system assessments.
Okay, so that's ruling things out. What about conditions that often come with AT-associated diseases?
Right. And there's some really significant ones. The big one is that increased cancer risk we keep mentioning.
Yeah.
The notes are quite specific here. Lymphoreticular malignancies, so lymphomas and leukemias, particularly acute lymphoblastic leukemia or ALL, are really common, especially in the first 20 years or so.
Okay.
Later in life, solid tumors might become more predominant, but that cancer risk is a major, major association.
And the immune problems manifest clinically, too.
Definitely. Immunodeficiency is very common. Lab tests often show low levels of immunoglobulins, IgA, IgG, sometimes IgE.
Right.
And you'll often see lymphopenia, meaning low numbers of lymphocytes, both B cells and T cells, including the CD4 and CD8 subsets.
And that explains the infections.
Exactly. That's why recurrent respiratory tract infections, chest infections, sinus infections are so frequent. Interestingly, the notes say severe systemic infections are actually less common than you might expect, but the respiratory infections are a constant issue.
Okay, let's talk numbers for a sec. How common is AT, particularly thinking about the UK, as our source specifies?
Yeah, the notes confirm it's definitely classed as a rare genetic disorder here in the UK. The estimated prevalence they give is quite a wide range, actually. Something like 1 in 100,000 up to maybe 1 in 300,000 people.
Quite a range.
It is. And they mention that these figures can vary a bit depending on, the population studied and the exact diagnostic criteria used in that study.
And here's that point I found really interesting. The carriers, people with just one copy of the faulty gene, they have risks too, don't they?
Absolutely. This is super high yield. Definitely flag this one. Heterozygous carriers, they don't have AD themselves, obviously. Right. But the notes clearly state they do have an increased risk of certain health problems compared to the general population. Specifically, reduced life expectancy overall.
Wow.
And an increased risk of developing cancer and also heart disease.
And wasn't there a specific cancer risk mentioned for female carriers?
Yes, spot on. Female heterozygotes have a notably increased risk of breast cancer. That's a crucial detail to remember.
Definitely one for the revision list. And linking back to risk factors, the prevalence being higher in populations with more consanguinity makes sense then.
Yes, exactly. The epidemiology confirms what we discussed earlier about risk. It pops up more frequently where consanguineous marriage is more common, just because the odds of both parents carrying that rare recessive gene are higher.
Okay, let's shift gears fully to the clinical picture. What does AT actually look like when you see a patient? How does it typically present?
It almost always shows up in early childhood, often between, say, 1 and 2 years old, maybe up to age 4. And the very first thing parents or doctors usually notice is the progressive cerebellar ataxia.
The coordination problems.
Yeah, problems with balance, unsteady walking. It becomes obvious as the child starts trying to master walking and movement.
So what are the absolute hallmark features we need etched in our minds?
Well, the two in the name are the big ones. Progressive ataxia, usually the earliest sign, and the telangiectasias.
Those little blood vessels.
Exactly, those small dilated blood vessels. They often appear a bit later than the ataxia, maybe around age 3 to 6, classically in the whites of the eyes, the conjunctiva. But you can see them on the skin too, areas exposed to sun, like ears, cheeks, neck. Then, rounding out the core features are the consequences of the immune problems, so those recurrent infections, and that increased risk of cancer.
Are there other signs mentioned in the notes that might be present?
Oh yes, there's quite a list of other things that can develop over time. Delayed growth and development is common. Slurred speech dysarthria.
Yeah.
Difficulty swallowing dysphagia.
Okay.
A characteristic eye movement problem called oculomotor apraxia, basically. Difficulty initiating smooth eye movements to follow something.
Right, I remember reading about that.
And a really important one. Marked sensitivity to ionizing radiation. Standard X-rays can cause much more DNA damage than usual.
That's crucial for management, too.
Absolutely. The more detailed notes add other potential signs like a lack of facial expression, sometimes drooling, decreased or absent deep tendon reflexes.
Okay.
Those pulmonary and sinus infections we mentioned, bulbar dysfunction affecting speech and swallowing, gonadal atrophy, and sometimes other movement disorders like dystonia or chorea, plus sensory neuropathy. It can be a very complex picture.
Wow, that is quite a constellation. It feels like a lot to remember. How can someone keep all those clinical features straight, say, for an exam?
Okay, here's a memory tip. Use the name itself. Ataxia and telangiectasia. Those are your two most visible defining features. Then think about that core problem, faulty DNA repair in rapidly dividing cells. That links directly to the immune system issues leading to infections and the increased risk of cancer. So AT match A plus T plus I plus C.
ATIC. I like that. Ataxia, telangiectasia, immune, cancer. That simplifies it. And if you were setting an exam question, how might this present?
Good question. Here's an example question tip. Imagine a vignette. A 4-year-old child, previously meeting milestones, started becoming unsteady around age 2. Now has obvious balance problems, difficulty walking straight. On exam, you notice fine reddish lines in the corners of their eyes. Mom mentions they've had 3 episodes of pneumonia in the last year. What key signs point strongly towards ataxia telangiectasia?
Okay.
You'd be looking for the progressive ataxia starting in early childhood, the presence of conjunctival telangiectasia, and that history of recurrent respiratory infections. That combination and the timeline are really suggestive of AT.
That really helps frame it. Okay, so we've seen the signs. How do doctors actually confirm the diagnosis? What investigations are key?
Well, it often starts with that clinical suspicion based on putting together the history and the physical exam findings we just talked about.
Yeah.
But the definitive step, the one that confirms it, is genetic testing. Looking for those causative mutations in the ATM gene. That's the gold standard.
Makes sense. What about lab tests? Are there any characteristic findings?
Yes, absolutely. There are some key lab investigations. One really important one to remember, super high yield, is the serum alpha-fetoprotein level, AFP.
Yeah, ASP.
Yeah, alpha-fetoprotein. It's typically elevated in the vast majority of people with AT. It's a really useful marker, though not entirely specific.
Okay, elevated AFP. Got it.
What else? Other labs would include checking those immunoglobulin levels we mentioned. You're often looking for low IgA, IgG, and IDOR, IgE.
For the immune deficiency.
Exactly. And lymphocyte subset analysis. That's where you count the different types of B cells and T cells to check for lymphopenia. The notes also mention something called in vitro radiosensitivity testing, like a colony survival assay, which shows how sensitive the patient's cells are to radiation. But that's more specialized, less common for routine diagnosis these days compared to genetics.
And imaging. You mentioned MRI before.
Yes, neuroimaging, usually a brain MRI, is often done. It helps assess the neurological side, and characteristically, it will often show atrophy or degeneration of the cerebellum, which fits with the ataxia.
Okay, so genetics first and foremost, then labs, especially, then AFP. Immunology checks, maybe an MRI. Any quick way to remember those?
Let's try another memory tip. For investigations, think GM. G for genetics, the crucial one. L for labs, especially that high level of alpha-fetoprotein. I for immunology, checking immunoglobulins and lymphocytes. And M for MRI, to look at the brain. GLIM.
GLIM, nice. Okay, so once you have the diagnosis, we know there's no cure, unfortunately. So what does managing AT actually involve?
Yeah, that's the tough part. Since there's no cure, management is entirely focused on supportive care. It's all about managing the symptoms and the complications to try and improve, or at least maintain, the best possible quality of life.
So what are the sort of general approaches taken?
The notes really emphasize close monitoring, watching growth, development, lung function, immune function. Then you have therapies.
Like physio.
Exactly. Physiotherapy and occupational therapy are vital for helping with mobility, coordination, and daily living skills. Speech therapy is also key for communication and managing any swallowing difficulties.
And the infections.
Managing infections is critical. That means prompt treatment with antibiotics when infections occur. Sometimes doctors might use prophylactic or preventative antibiotics. And for those with severe antibody deficiencies, immunoglobulin replacement therapy giving infusions of antibodies might be needed.
Okay.
Regular cancer screening is another absolutely essential part of long-term management. And genetic counseling for the family is important too.
Makes sense. Are there any specific treatments mentioned for the neurological symptoms, which often seem the most disabling?
Yeah, the neurological symptoms are definitely challenging. The notes list a few things that might be tried, but often with limited success, sadly. For things like dystonia or other movement issues related to the basal ganglia, they mention LDOP derivatives, dopamine antagonists, or anticholinergics. Some medications like amantadine, fluoxetine, which is an SSRI, and buspirone are listed as potentially helping a bit with balance, speech, or coordination in some individuals. And for tremors, things like gabapentin, clonazepam, or propranolol might be used.
So trying different things to see what helps that individual.
Pretty much. And managing that swallowing difficulty, the dysphagia, is also vital to prevent aspiration pneumonia. That might involve simple things like thickening liquids, or in more severe cases, might require tube feeding, like a gastrostomy tube.
Right. And what else is important in the overall management plan?
The notes really stress the need for a multidisciplinary team. You need neurologists, immunologists, pulmonologists, oncologists, therapists, dietitians, all working together.
Makes total sense for such a complex condition.
Definitely. Other practical points mentioned, some suggest high-dose vitamins, though evidence might be limited. And crucially, remembering that radiation sensitivity, minimizing exposure to X-rays and other ionizing radiation is paramount.
Yeah, avoiding unnecessary CT scans, for example.
Exactly. And making sure everyone involved in their care knows about this sensitivity. Recognizing the high cancer risk means getting that genetics referral sorted early and putting regular screening protocols in place. Oh, and the notes also highlight the importance of supportive services, education support, psychological counseling for the patient and family, and eventually palliative care planning.
That covers a lot of ground. Did the notes mention anything about sort of future treatments on the horizon?
Yes, briefly, they do acknowledge potential future avenues like stem cell transplantation or even gene therapy are being researched. But, and this is the key takeaway for now, these are not current standard treatments. They're still experimental. So the focus for today's management remains firmly on optimizing that supportive care based on current knowledge.
Okay, understood. Looking further ahead then, what's the typical prognosis for someone diagnosed with AT? What does the future usually hold?
Well, it is a progressive disease, as we said. So, unfortunately, the prognosis involves gradual deterioration, particularly neurologically.
Yeah.
But it's quite variable.
Variable depending on what?
Depending on how quickly the neurological symptoms progress, how severe the immune deficiency is, and importantly, whether or not cancer develops, and how treatable it is.
Right. What does that mean in terms of lifespan and function?
The notes are quite clear that there is a reduced life expectancy. They quote, median survival figures typically falling somewhere in the 20s or maybe early 30s.
Okay.
Sadly, the most common causes of death tend to be respiratory failure, often due to chronic lung disease from infections or aspiration or complications related to cancer.
And functionally?
Functionally, wheelchair dependency is common by the teenage years for many individuals. Communication also becomes increasingly difficult because of the combination of dysarthria, slurred speech, problems with controlling hand movements for writing, and that oculomotor apraxia affecting eye contact and reading.
That sounds incredibly challenging. Is prenatal testing something families consider?
The notes mention that prenatal testing is technically available for families known to be at risk.
Right.
But it's not routinely performed everywhere. Partly, they say, because the ATM gene is very large and complex, which can make the testing itself quite challenging and expensive.
Yeah.
However, the notes do emphasize that good multidisciplinary care, vigilant monitoring, and intervening early for complications can definitely improve quality of life and might potentially help extend lifespan compared to historical outcomes.
That's important to remember. So, finally, wrapping things up, what are the main problems or complications that people with AT and their families frequently face over time?
Based on everything we've discussed, the most significant complications really stem directly from those core affected systems.
Okay.
So you've got recurrent infections, which can be severe, especially respiratory ones, because of the immunodeficiency. That leads to chronic lung problems for many.
Right. The respiratory issues.
Then there are nutritional difficulties and swallowing problems, potentially leading to aspiration and malnutrition.
Mm-hmm.
The big one, again, that significantly increased risk of cancer,
Yeah.
particularly lymphomas and leukemia early on, but other cancers too. Progressive neurological impairment, which inevitably leads to loss of mobility, independence, and difficulties with communication. And we shouldn't underestimate the huge psychosocial challenges for the individual living with the condition and for their family providing care and support.
And the goal of management is really to anticipate and minimize these.
Exactly. The whole management strategy is geared towards minimizing the impact of these potential complications, enhancing quality of life as much as possible through proactive care, regular surveillance, early detection of problems. That's absolutely key for timely interventions and trying to manage things appropriately.
Wow. Okay, that was a really, really thorough deep dive into ataxia telangiectasia. You've really pulled out the key threads from those revision notes, linking that faulty ATM gene to all the widespread effects.
It certainly highlights how, a defect in just one single gene can create such a complex multi-system condition,
Yeah.
affecting everything from how you walk to your immune system to your cancer risk. Understanding those connections, I think, is vital when you're revising this topic.
Absolutely. And it makes you appreciate how a focus session like this, just digging into one condition using specific notes, can really help consolidate that complex information efficiently. It helps make it stick rather than just reading pages and pages.
Definitely. And, thinking about the ongoing challenges,
Mm.
particularly in treating the progressive neurological decline and tackling that persistent cancer risk,
Mm-hmm.
it does raise a pretty big question, doesn't it?
Which is?
Well, how might future research actually bridge that gap? The gap between our now quite detailed understanding of what the ATM protein does or should do,
Mm-hmm.
and developing truly effective therapies that can maybe halt the progression or even reverse some aspects, rather than just managing symptoms.
That's a really profound thought, the challenge of translating the basic science into real clinical breakthroughs for these genetic disorders.
Exactly. It makes you think about those translational hurdles in genetic medicine. It's a long road.
It is. Well, that's certainly something for everyone listening to mull over. If you found this deep dive helpful for your MSRA revision or just for understanding AT better, you might find even more support and targeted resources over at passthemsra.com.
And also at freemsra.com for some great free materials, too. Definitely worth checking out if you're prepping for the exam.
Absolutely. Consolidating your knowledge with resources like these and maybe revisiting deep dives like this one can really make a difference.
Agreed.
Thanks so much for walking us through all of that today.
My pleasure. Always good to break these complex topics down.